There are a handful of conditions or procedures where there is enough volume to make a bundle structure make sense and, make sense from a risk sharing perspective and an opportunity to spread the risk and also make the kind of contracting effort worth the value that it creates.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. We're very pleased to have with us today David Terry, the founder and CEO of Archway Health. He's a thought leader and frequent speaker on bundled payments and other payment reform initiatives. With over 20 years' experience in healthcare, he's recognized as a trusted strategic advisor for providers all along the care continuum. He has successfully led care and risk management initiatives with primary care physicians, specialists, acute care hospitals, pediatric health systems, skilled nursing facilities, home care companies, and hospice providers. Can we say more? Dave holds an MBA from Harvard Business School and a BA from Columbia University. He serves on the board of The Bottom Line, a national educational nonprofit, and is past board member of the Harvard Business School Health Industry Alumni Association. He has authored a number of teach case studies on entrepreneurial healthcare companies. Dave, welcome to our podcast.
Thanks, Bob. Great to be here. Thank you for the invitation.
Dave, as our name implies, we're the Business of Healthcare podcast, so we try to explore topics that are more business-oriented than clinically oriented. There cannot be a topic more business-related than payment methods. We always like to start off with some of the fundamental basics on any topic and not assume that everyone listening is an expert yet. Many in our audience look to these podcasts as a fundamental part of their education. But we all recognize that the American medicine is undergoing a fundamental structural reform. Doctors are moving from a craft-based practice to a team-based practice. And interestingly, the transformation change in the medical delivery model is being driven by payment reform. So maybe we can start with a bit of history on payment methods and what worked and what didn't work and what we're seeing in the marketplace today.
Yeah, good question. So, obviously most of our system is structured on fee-for-service and has been, fee-for-service based for a long time. There have been, I kind of describe it as a, roller coaster of different innovations over the course of my career. So I've been in healthcare since 1990. So approaching 30 years. And we've had waves of global capitation or pay for performance or carve outs and those types of things. But fee-for-service continues to be the predominant payment method. Since the Affordable Care Act and I would say related to the recession, there's been a greater push towards value-based payment and away from fee-for-service. I agree that is, payment is certainly core to the business aspect of healthcare, but I would also say it's related to quality and clinical process as well. Our mission at Archway, when we founded the company, we're focused on our mission is to fix healthcare through payment reform. And that's purposeful because, our view is we can't really improve process and quality and reduce costs unless we change the way we pay for it. And the fundamental problems with fee-for-service as we see it is it really does not, it's a piecework system. It rewards folks for doing their job, but it doesn't reward a great outcome or reward for value like we see in most other parts of the economy. And so, our view is fee-for-service is a big part of why healthcare isn't working as well as it should be. And we need different forms of payment to make it better.
So it's safe to say that fee-for-service, it primarily rewards quantity and not so much the quality or efficiency. Is that right?
Yeah. We had a meeting a few years ago with a large payer here in the Boston market. One of the specialists we work with, we look at a lot of data, and our data says he is arguably the best hip surgeon in the state of Massachusetts. And we look at quality data, outcomes, patient satisfaction, as well as total cost of care. And he's just a great doctor, and the results prove it on a health risk adjusted basis. When we work with specialists like Steve, we spend time looking at the data, but we also really try to understand what great clinical process looks like. Because what we find is when we can identify these specialists and get to meet them, they have a different way of treating their patients that leads to these better outcomes and lower costs. And so Steve and I met with some of the contracting folks at this particular payer, and we showed the data. We outlined the process. He even has a video of some of the techniques he uses that differentiate him. And at the end of the presentation, the payer folks were complimentary and essentially said, "This is great. You're clearly very good at what you do." But the comment they made was, if this process is so great, why doesn't everybody do it that way? And one of the answers is they pay everyone the same. They pay $1,800 for every hip surgery for every provider or every surgeon in the state. And so it doesn't reward innovation or new ways of doing things. It doesn't reward the folks who are really, really expert at this versus the folks who are, not, or maybe doing multiple different types of surgery. And what we've learned is just like in school, there's a bell curve for everything. And we see those bell curves over and over again when we look at quality by specialist or by health system or various providers, when we look at the cost of care. And there's more variability than you would expect. And we see, 30, 40% variability around the mean in total cost of care when we look at it on an episodic basis. And our goal really is to find those providers who are great and partner with them to manage care in a different way. And fee-for-service really doesn't support that or promote that model.
So fee-for-service, from a historical perspective, it's the de facto, it's the status quo. It's always been fee-for-service. So as you look at the marketplace and you start to find these unique situations where you can find people that have a specialty, they've had efficiency, they've got methods that are much better, and you try to bundle these together to come up with a bundled payment method. Is this something new? I mean, what's the history on a bundled payment strategy? This isn't a brand new concept, is it?
No, it's not a brand new concept, but it is relatively new in being implemented at any scale. So as part of the Affordable Care Act, there's a line or two in there directing CMS, Medicare, to create a bundle payment program. And so in 2011, they announced the creation of the first sizable bundle payment initiative called Bundle Payment for Care Improvement. There were a few other demonstrations prior to that. There was the ACE demonstration, and it was a cardiac bundle program, in the mid 2000s. But Bundle Payment for Care Improvement is really the first sizable initiative. And the rules came out in 2011. The first providers went live in that program in 2013. Medicare has since created a follow-on to that called the Bundle Payment for Care Improvement Advanced program that started this past October. There's also the Oncology Care Model, a Medicare Cancer Bundle program, and there's the Mandatory Comprehensive Care for Joint Replacement program. So I would say at any scale, these programs have been live for about 5 years, 5 or 6 years in the Medicare market. And Medicare, far and away, is the leader of these types of contracts. There are a handful of payers and some employers that are doing this. Horizon Blue Cross in New Jersey has the largest commercial bundle payment program that we're aware of. United and a few others have some joint replacement programs. There have been commercial transplant bundle payment programs historically for really high cost, complex care. But it's relatively new. There are about 2,000 providers across the country who are participating in different forms of Medicare bundle payment contracts at this point.
Yes, I saw a map. It showed here's where BPCI, the Bundle Payment Care Improvement, is being used. It was a map of the United States, and it had a lot of dots on it. But I didn't know how pervasive it really was. Those maps can be misleading. Is this getting the private insurers? Are they catching on to it as well? You said Medicare is actually leading this initiative, but what about the private insurers? Do you think that is catching on? And what obstacles need to be overcome to get them to buy into this whole concept of change?
Yeah, I would say it's catching on. It has been slow, to be honest, in the commercial market and slower than we would have hoped. I think there are some real practical reasons for why that's true, and potentially some strategic reasons for why it's true. On the practical, why it hasn't caught on as rapidly as we might have hoped. On the practical side, there are a handful of conditions or procedures where there is enough volume to make a bundle structure make sense, and make sense from a risk sharing perspective and an opportunity to spread the risk, and also make the kind of contracting effort worth the value that it creates. So deliveries, joint replacement, maybe stents and a few others. But in most procedures and in most conditions in the commercial market, sample size gets pretty small pretty fast for any given condition. So even if you're a sizable payer, you don't have that many, lung cancer patients in a given year. And to have a effective, bundle contract for lung cancer, you have to have a payer that's willing to do it, and then a provider on the other side of that contract. And sample size gets even smaller, obviously, when you need two parties involved. And these contracts are complicated. They're a lot of work. They require real trust between the payer and the provider, which sometimes can be a challenge because there's, contentious contracting, historical contracting relationships. And so it's tough, can be tough to kind of do these contracts beyond a few clinical areas. And I think that's slowed things down. It can be complicated. We just published a paper in partnership with the Health Care Transformation Taskforce that outlines the 10 elements that are essential to a bundle payment contract, and kind of easy steps for each of those elements to walk through. Because we hear complaints from providers and payers that bundle payment contract is complicated. All of the things that are need to be part of a bundle payment contract, like episode definitions and risk sharing and quality metrics, they've all been considered in different ways over time, and we're just trying to create a little cheat sheet for folks to be able to walk through those issues that might create complexity. But the big complaint that we hear from folks, and I think one of the deterrents, is it can be complicated to make these contracts happen.
So the initial success has been in these surgical procedures with specialists primarily, and it's not really grown out into these other chronic disease or primary care markets. Is there a trend for it to go that way ultimately, you think, or will it just always be limited to these specialty groups?
Well, I would say it's certainly from a primary care perspective, I think of global capitation as kind of the way to bring primary care into value-based care. And then bundle payment would be the way to create opportunity and accountability for specialists. But I would also say that we think there's opportunity using the bundle payment model in any type of condition, whether it's surgical or medical. So we've had success with, congestive heart failure patients, with COPD patients, with patients who've been admitted to the hospital for sepsis. We've had success in cancer. And then also we've had success in procedures like joint replacement and CABG and stents and those types of things. And the criteria we look for are, relatively high volume of patient population, relatively high cost per case, and significant variability in the cost and the quality of an episode. And when we look at things like CHF, for example, in Medicare, the average cost to care for a congestive heart failure patient who's been admitted to the hospital, the cost to Medicare over 90 days is about $35,000. But we see about 30 to 40% variation around that $35,000 mean on a health risk adjusted basis. We also see a 46% readmission rate and a relatively high skilled nursing facility rate with considerable variability. And our perspective is, with that much variability and that much utilization, if we focus on it like an episode, as opposed to just a fee-for-service model, if we focus on it like an episode, we should be able to get 10 to 20% improvement, reduce readmissions by 10 or 20%. We know we're not going to eliminate all readmissions, but through working with great specialists and better process management and better patient engagement, we can typically see 10 to 20% improvement. And that's true everywhere. We see that in cancer. We see that in COPD. So it's really more about the transition from this piecework fee-for-service model to a comprehensive, someone's paying attention to the process and really managing it for a better outcome and for value. There's just a ton of opportunity all over the place for improvement if you can make that transition.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
It's almost like a common sense approach. I mean, if I was going to build a car today, I wouldn't go out and buy all these pieces and try to put them together and make a nice car. The pieces might be good, but when you can coordinate all the different activities associated with this, and when you start to coordinate the specialists and the facilities and organize that, you would automatically, common sense, expect to get some efficiencies out of there, and you probably have better outcomes. Is there a consumer benefit? Do you see this bundled payment as an advantage for consumers who are actually shopping for some of these services, et cetera? Is there a plus there for them as well?
Yeah, absolutely. So our approach, what we're working on now is we're spending a lot of time with self-insured employers, with the really two main aspects. You're taking two main aspects of what we learned from these Medicare programs and bringing it to the self-insured employer market, and really with the goal of helping their employees have a better experience when they're sick, when they need specialty care, and are in some sort of specialty care episode. So those two components are, I talked about one of them, which is really trying to understand what does great specialty care process look like for all different types of conditions. So, we partner with that, hip surgeon, Steve, I mentioned, where we have a very good understanding of what good process looks like and how to find doctors who are great at this. We do a lot of work in cancer, as I mentioned. So we know what good clinical process looks like for a patient who has lung cancer or breast cancer. And so we try to find those doctors in a market who are really good at what they do, and then partner with them to look at data in new ways and continue to improve their process and drive towards better outcomes. The second part of the process is what we call a virtual episodic model, where rather than spending a lot of time trying to create a challenging contract, the employer, if they're self-insured, already holds all the risk. We can use the same tools we use in Medicare to help navigate the process in partnership with the patient and the physician for quality and for value. And I'll give you a personal example. So my son, Henry, he's a freshman in college. He was having shoulder pain. And so we're here in Boston. I looked at our data. I found a shoulder surgeon who looked like they were really good at what they do. I asked some of my orthopedic friends if they knew him and thought that he was a top tier doctor, and they did. And so we got an appointment with him, and we had Henry had an X-ray and a physical exam with the physician and a fellow, actually. And I was impressed with the exam. And the end result was that he either had tendonitis and needed a shot, or he had a torn labrum and he needed surgery. But we needed to get an MRI. And so this doctor happened to be at a large academic medical center in town. He referred us to an MRI at the hospital for 2 days forward. And I didn't say anything, but I took the order and took a picture of it, and we started shopping. We ended up finding out that the price of the MRI at the hospital would have been $2,900. I would have paid $900, and my insurance company, Aetna, would have paid $2,000. We shopped around and we found a comparable MRI for $331. I pay $331 and Aetna pays nothing. We had to make 3 phone calls to the physician's office to say that we were going to get the MRI, but we were going to get it somewhere else. And this other providers in my payer network, they're just outside of the provider network. And we had to make 2 phone calls to Aetna for some reason to save them $2,000. But ultimately, we got the MRI, for $331. Went back to the doctor with the MRI, and thankfully Henry didn't need surgery. But we also can see in our data that this particular surgeon, he looked 20% of his surgeries are at a community hospital that's about three miles from my house, and the other 80% are at an academic center that's about 2 or 3 miles from my house. When the surgeries are performed at the academic center, they're about 60% of the price as they are at community hospital. We would have been able to manage this whole process with a great surgeon for about $8,000 less than if we had just let it play out kind of normally. And we see that everywhere, right? So when we think about it from an episodic basis, there's a bell curve for every decision you make along the way, right? So if you need shoulder surgery, you're going to have an X-ray, an MRI, a physician, a surgeon, an OR, and a physical therapist. Each one of those providers along the way has a bell curve for quality and a bell curve for the prices that they charge for their services. And we're really, really focused on trying to figure out what those look like and how to manage that whole process for quality and for value.
That is a great example. That really, really amplifies the reality of the world that we live in and some of the inefficiencies that we find in the healthcare system. I kind of would like to have a healthcare environment which would treat me like if I'm buying a house, having a house built. If I find someone to build me a house, I know what the price is. There's a single price. The builder gets paid when the house is inspected and I move in. There ought to be a provision in there for some type of change order if I want a better roof or add a pool, some provision for that. But it ought to be a win-win situation where the provider makes money, they don't lose money, and the homeowner gets a good house. And obviously, the provider shouldn't be responsible for any out-of-warranty items like a flood or something. And if you treated a doctor arrangement like that, where it was bundled and well-defined and efficient, I think would have a pretty good outcome. So, Dave, what are some of the obstacles that you're running into? Does this new payment method require a change in physician behavior? And are there things that you can do that can motivate or educate the need for this change? You mentioned working with the providers and working with insurers, but what about the doctors? Is there a change in getting them away from fee-for-service into a quality-based environment? Do you have ideas along that line?
Yeah, so it definitely does require different ways of thinking on behalf of physicians and the teams around them. And we spend a lot of time working with physicians to kind of help them understand that and move them in this direction. But also we put resources around them and work with their practices to put resources around them so that they can continue to do what they do and be productive without having to have too much change. But let's say some of the things are, one where we've had success is where the physicians are data driven and interested in improving and interested, kind of share our perspective that there's a lot of room for improvement in healthcare. And, so willingness to change and a willingness to improve and use data to do that is a big requirement. The other thing we found, and this might be a little bit paradoxical, but when a patient is sick or has had a procedure, we like to have the specialist and the specialist team involved in that patient's care for a longer period of time and not have that patient go back to their primary care physician or to another provider until they're really through that episode. And the reason for that, I learned this from a knee surgeon that we work with, and because the literature says the best way to avoid, or this a few years ago, it may have changed now, but the literature that I was reading said the best way to avoid a readmission is to have the patient re-engage with their primary care physician within a week or so of being discharged from the hospital. But when the specialists we work with started in these programs and started taking risk and moving from fee-for-service into bundles, the feedback we got was that's actually not right. And that they wanted their patients to come back to them post-surgery rather than go back to their primary care physician. And the fundamental reason is that primary care physicians just don't see that many red post-surgical knees on a regular basis. And, knee surgeons and their teams see them all the time. And when you don't see something a lot, you tend not to do the best thing. And so oftentimes, patients will get inappropriate pain meds prescribed or have excess ER, go to the ER when they don't need to, or get readmitted when they don't need to, or have more imaging exams done. When if you had an orthopod look at it, they could say, geez, you got a red knee, but this is part of the recovery. And, you just need to, kind of wait it out a little bit. So more involvement of the specialists in the process and the specialist teams is something that's different. and it does require some training and a little bit more attention, but the value that it creates is significant.
Okay. Well, Dave, kind of wrapping things up, tell us just a little history here on your finding Archway. What motivated you to do that? You've had a long history of leadership roles, and tell us a little bit how Archway goes to market too, and how you focus in to help these organizations.
Yeah. So really, Archway. I mean, we founded Archway in response to Medicare creating these bundle payment programs. And my career, I worked, as I mentioned, pretty much exclusively with providers in different types of care and risk environments. And, one of the observations, and that's true of many of the folks on our team here, and one of the observations we had is there really hasn't been that much focus on specialty care and how to improve process and reduce costs for specialty care. A lot of focus, payment reform, there's been a lot of focus on primary care and capitated models, a lot of focus on hospitals and hospital consolidation, but not a huge amount of focus on specialists and specialty care. And as we look at the data, somewhere between 70 and 75% of healthcare dollars are spent when patients are sick and in some sort of specialty related episode, whether it's acute or chronic. And so, it really was created in response to this observation that there's a lot of opportunity to improve process for specialty care. And the Medicare bundle payment programs really were the beginning of creating a business model for that. We go to market in a couple different ways. So in the Medicare programs, the way they work is they have periodic open enrollment periods when providers can get into these programs. And so when those enrollment windows are open, we're very actively marketing to providers to help them evaluate their opportunities and educate them on the programs and help them get in. And then we share risk with them in those programs, and we help them manage those programs. We're kind of becoming an insurance company. So we're also, for providers who are taking risk in any type of value-based care contract, whether it's a bundle program or an ACO or a commercial risk contract, we can provide stop loss coverage to them. So if a provider says, I want to be in a risk arrangement, but I never want to write a check for over $1 million, say, in a year, we can analyze their data and provide stop loss coverage alongside of tools to help them manage that risk. Obviously, we're seeing more and more providers taking risk, but many of them, when we talk to them, don't have the analytic tools necessarily to understand exactly what that risk looks like, how much exposure they have across programs. So talking to a provider just yesterday, they're in a BPCI program, they're in the next-gen ACO, they're in some commercial contracts, and some of their providers are in the oncology care model. So they've got over a dozen different risk contracts. They want to analyze all that risk together and understand how much risk they have, how much exposure, and should they be thinking about sharing that with an underwriter. So we're starting to do more and more of that. And then the third area, as I mentioned earlier, is we're starting to talk more to self-insured employers to help them also manage their specialty spend and improve that specialist kind of identifying the best specialists their employees should be going to, and then working with their employees to have a better experience.
Excellent. So one last question, Dave. Archway, how'd you come up with the name Archway?
That's a good question. When it's hard to name a company these days, Bob, there's a lot of that. So we looked at a number of different things. There's in the Boston Harbor. I don't know if you've spent any time in the Boston Harbor, but there's the Boston Harbor Hotel, which is one of my favorite views.
Mine too.
From Boston Harbor, it's a beautiful arch that kind of sits next to the harbor that I've always liked, and that was one of the inspirations. We looked at a number of different names, and it can be challenged to find something that you feel excited about that also is available, and you can get a URL and all that stuff. But it's a combination of we see of healthcare coming through a new kind of in a new phase, and inspiration from the Boston Harbor Hotel, and what URL we could buy.
Awesome. Well, I got to thank you again, Dave. Your enthusiasm, your intellect, your experience, all being shared with us is of great value. So we appreciate you being part of our program, and we wish you all the best success.
Well, thanks, Bob. This was great. I hope this was helpful, and we'd love to chat sometime again.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.